Hello, everyone. So we are returning here again with a learning case. This case was presented by Dr. Poojitha, senior resident of our department, during the intra-departmental discussion. The video recording is now being done by me. So based on the clinical history, 51-year-old female presented with swelling over the anterior aspect of the left knee since 3 weeks. There was pain at the region of the swelling. However, there was no history of trauma given by the patient. The case was referred to us from Department of Orthopedics for radiography of both knee joints and then for ultrasonography of that targeted swelling. On asking regarding previous investigations, there were none available with the patient. So the modalities, as I told you, was radiography and sonography done in our institute. So on seeing the frontal radiograph of both knee joints, we could find that there was KL grade 4 osteoarthritic changes. And on lateral views, there are joint effusions in the suprapatellar recesses. However, on close inspection, there was increased soft tissue opacity noticed over the anterior and the inferior aspect of the left patella. The same findings were conveyed to our clinical colleagues. On ultrasonography, we found that there was a well-defined heterogeneously hypoechoic lesion measuring approximately 3.8 into 3.6 by 1.5 centimeters in the subcutaneous plane above the tendon over the anterior aspect of the patella. And this swelling was exactly at the prepatellar bursal site. Usually, it is suggested that these swellings at the prepatellar area should be done with a very light hand, or a two-hand technique can be used for doing the ultrasonography. The lesion had a spongiform appearance due to both solid and cystic components within, and there was no increased vascularity within the lesion. However, there was minimal increased vascularity noticed at the peripheral or at the periphery of the lesion. So the final diagnosis given by us was prepatellar bursitis, as there was hypoechogenic collection with septations and increased perilesional vascularity, suggesting fluid accumulation and inflammation of the bursa. So on reviewing the literature, as per the consensus conference statement of Society of Radiologists in ultrasound regarding ultrasound of soft tissue masses, all the soft tissue masses have been divided broadly into 4 categories based on the ultrasound features. And the categories are reliably benign masses like lipoma, fat necrosis, epidermal inclusion cyst giving a pseudotestis appearance, peripheral nerve sheath tumors where you can see a nerve exiting or entering into the lesion, vascular malformations or ganglion, pseudomasses like bursitis, abscesses, foreign body or hematoma, lymphadenopathy, which could be either reactive, hyperplastic, secondary to lymphoma leukemia spectrum, or secondary to metastatic disease, non-specific neoplastic masses like soft tissue neoplasm, as in cases of soft tissue leiomyoma, pleomorphic sarcoma, or melanoma, etc. So there is a beautiful article and there is a consensus conference statement given by the Society of Radiologists in Ultrasound pertaining to the superficial soft tissue masses on ultrasonography. And there they have described all these categories and all the typical and atypical findings of all the pathologies I just mentioned in the previous slide. So coming to our pathology, that is the bursal disease, the typical findings include usually a hypoechoic lesion, which is well circumscribed and showing variable vascularity. And the lesion is usually located at an anatomical site of bursa or at the site of extrinsic pressure, like adventitious bursitis that we see usually in our department along the lateral malleolus of the lower limb. The atypical findings for bursal disease include substantial solid components within the lesion and vascularity in those solid components. And when atypical findings are found, then recommendation given by the consensus statement is that contrast enhanced MRI should be performed. Usually, management is guided by clinical history given by the patient, possible causes being trauma, extrinsic pressure, inflammation, and proliferative synovial process. And if there is a concern for infection, then aspiration or synovial biopsy is recommended. I would recommend that all of you, after seeing this case, should read this particular article to further your knowledge pertaining to ultrasonography of superficial soft tissue masses. Thank you very much.